Hello and welcome to our Johns Hopkins University Grand Rounds for Biomedical Informatics and Data Science. I am Paul Naji, and it's really my pleasure to be here today and introducing a close colleague of mine. Today's Grand Rounds will be given by Dr. Saptarshi Purkayastha. He is an associate professor and program director of health informatics at Indiana University in the School of Informatics, Computing, and Engineering. Dr. Purkayastha's research focuses on healthcare informatics, particularly at the intersection of EHR systems, artificial intelligence and medical imaging, and health technology and implementation in resource-limited settings. He has led multiple funded research projects, including work supported by the NIH, NSF, and Bill and Melinda Gates Foundation. And his recent work includes developing AI assistants for radiology systems and studying the implementation of health informatics in clinical settings. As an educator, he teaches courses in biomedical analytics, health information standards, and EHR systems. He has mentored numerous graduate students and serves as an affiliate scientist at the Regent Street Institute. He is also actively involved in open source healthcare software development, leading projects with Libre Health, and has contributed significantly to global health initiatives through his work with organizations like the World Health Organization. It's really my pleasure to introduce Saptarshi today. Saptarshi and I are colleagues for many years, and in particular, he has a leadership role with the American Medical Informatics Association in our academic forum, where he leads the Professional Master's Educations Committee. And together, we've been working on ways that we can help modernize informatics education, and he's been really doing a lot of innovative work at Indiana on being able to provide as much realistic real-world training for informatics students. And so really, it's a pleasure to be here with Saptarshi today. If you have any questions, please add them to the Q&A. We're going to have Saptarshi give his talk, and then we're going to have a Q&A discussion period after his talk. Saptarshi, thank you so much, and welcome.
Thank you, everybody who's attending the session. I really appreciate and I hope at the end of it, I get some feedback and we get some feedback because it's very collaborative, this entire work that we're doing. I'll quickly get into that I have nothing to disclose. These are some objectives. These are my affiliations. I'm thankful to all the funders who have funded my past work. And this is sort of the broad agenda of today's talk. I'll give you a epistemological base of what I want to talk about. So what sort of makes me and my worldview. And then I'll talk about a little theoretical base through which this entire idea comes forward. And then we are going to talk about a few teaching cases over our experiences with different electronic health record systems over the years in teaching health informatics. And then some of the future work that we think is going to be exciting to be able to do this. So I was born and brought up in Mumbai. I did my undergrad and grad degrees there. I worked with OpenMRS, which is a medical record system that brought me back to health informatics. It sort of shaped my career. And then I worked with the government of India in their Ministry of Health. And then there I was doing things that I wanted to do more research on, and that's what took me to Trondheim and Norway. So I understood a different way of life, and some of my work has taken me to places like North Korea. I highlight this out of all the other places because of the deep insight that I learned here, which is very different from the rest of the world. And I found resilience of people who are disconnected, but with the skills and knowledge that they've gained, that resilience has taught me something more than me teaching them how to use EMRs. So primarily my work there was to help them learn about electronic medical record systems and national resource centers. And then as part of my PhD work, I also worked in Malawi, understanding the need of community health systems and strengthening them through mobile architectures. For example, this on the left is a road that gets filled with water, and so transport is really difficult, which is why you need infrastructure that should be able to support healthcare information and delivery. So sort of my um, work spans these three areas: public health, mobile sensor technologies, and and medical records. I work at the intersection. I call this intersection as teaching learning infrastructures, where humans and machines learn together. And the philosophical of our epistemological base begins by that information is care. Like if providers get um, good history about about a patient, have good information, then they can provide better care. So with that sort of philosophical base, I talk about two approaches that I take in teaching. First is critical action research. So people who come from educational background or from sociology probably understand that there are no subjects but partners. So students, educators, communicators are all partnered together in observing, reflecting, planning, and acting on things. So if there is what I'm going to talk about today is about electronic health records and data from electronic health records. Then how do you observe the way in which people are using that data, students are using that data? We critically reflect as issues that should be improved upon, because nothing in the world is perfect. Then we plan on how we implement that change. We make that change in practice. We observe what change has happened due to that new practice, so on and so forth. And it's an iterative process where continuous feedback is sought out of the way we teach health informatics in this case. So critical action research is one of the theoretical bases through which I understand this world. And then the other approach is through a constructivist approach in guided inquiry learning. So the theoretical base says that the four levels of inquiry are such that there is the confirmation inquiry, there's the structured inquiry. What I think at the graduate level is important is guided inquiry. So basically, knowledge does not go from the instructor to the student, but rather it's constructed through student-centered practices. And what I'm going to talk about today through the use of EMRs to teach health informatics is in that philosophy, which is that we do use um, knowledge from students, construction of that knowledge, and that's where uh, magic happens. That's how knowledge happens, and that's how knowledge is gained rather than transferred from the instructor to the students, rather than it's constructed through collaboration. So POGIL, which is process-oriented guided inquiry learning, is the philosophical approach that we take, which is we describe processes to discover concepts, but the concepts are then discovered together between the instructor and the student. So with these two theoretical bases, I will move forward to the next part, describing some of the ways that we've tried to implement EMRs through what I describe here as observe, reflect, plan, and act over the years. So I'll start with some of the use of desktop EHRs. Um, GNU Health is one of the first things we tried, and GNU Med, which shouldn't be confused by it. But what we discovered is that it did not have the same aspects as an entire health system would need in terms of both the data that's available, but also the workflows that have to be covered. One of the main sort of philosophical ideas behind this is that, and epic hyperspace is another example, is that you do not want to construct knowledge by giving only a picture of a car or picture of an environment and expecting people would be learning how to drive a car, right? You have to be in the car, at least in simulation environments, or in real cars, to be able to learn driving, right? So with that idea that you have to be able to use an EMR that covers the competencies required for health informatics, and then you will be able to gain begin or be able to create the mental model that's necessary to use and innovate in an EMR. So we did some work on open source EHRs, and I'll get to why open source. But we compared a lot of different EMRs on what they are. So focusing on interoperability, which is one of the meaningful use goals. We looked at compared OpenEMR, OpenEHR, OpenMRS, GNU Health, or Shara Vista on these different factors to identify what kind of modules or what kind of workflows do they support. We then also looked at privacy and security focus of these different EMRs. And this is all published in a journal article. We also compared performance, speed of some of these. But this is where I begin our sort of experience on how to build EMRs that will allow us to learn to work with data, but closely following the workflows within a real world health system. So OpenMRS is a medical record system, a platform that are shared by many different EMRs. So OpenMRS is very much a platform that can then be modified by the end user, implementer, if I may say, who's then customizing it to a workflow of a specific hospital or a healthcare setting. So it does not make a lot of opinionated um, guesses of what the health system does. So it's a very open platform, and people have built many proprietary EMRs on top of this, as well as distributions which bundle a lot of applications together to distribute an actual deployable EMR. So OpenMRS, I would say, is more of a platform that can then allow you to build EMRs on top of it. And people have built Kenya EMR, for example. All of Kenya, or at least the public health Kenyan facilities, have been asked to use it. Similarly, Uganda has done some work on customizing it for the Ugandan government health facilities. So these are widely customized, very different looking EMRs that are built on top of OpenMRS. So what it allows you to learn or teach in some sense is how do you build EMRs of your own that fit the needs of a clinical setting. So students can really truly understand what the context is and then fit the needs of the context through a platform that they can customize. So that's one of the strengths of this platform, but it does not have it requires competencies or skills where you can customize an EMR. So it gets into the nuts and bolts of an EMR. In particularly, I'm going to talk about some of the analytical tools that are available within this to analyze data. I'll begin with the reporting module. The reporting module is an analysis reporting tool within OpenMRS. It's a module that allows you to design reports of different kinds. So for example, you can do a cohort renderer, you can do a CSV export. If you wanted to use other kinds of tools, you can export it in Excel. You can create an HTML that looks something like this. So think of you're doing HEDIS measure reporting for the CMS for some quality improvement initiative or clinical quality measures, right? So if you want to create a clinical quality measures report or an HEDIS dataset export that you want to send, then you could use a module like this, and you can customize it in the way you want to. So it's a very platform, like I said, view where you can customize what should be produced from this. I'm giving you one example here, and then these links have a lot more details of how you can do this step by step. So if anybody wants to get into the depth of creating reports to do further analytics on the data that's within the EMR, this can allow you to do it. You could also take a more nuts and bolts approach um, for creating a report. And that would look something like this. So this is an example that I am showing here. Basically, you can take, here I'm trying to design a clinical summary. So in some of our assignments for courses, what we do is ask the student to write a data set definition. So this is an example that will allow you to create a clinical summary or a discharge summary. And this is basically an ICU discharge summary that you first write your data extraction for. You design a template where this data would flow into. So for example, this is doing the patient identifier. So the identifier you see here in the final output looks something like this because it fits into this report template definition that's been defined, right? So as you can see, this is a lot more nuts and bolts approach than the first approach where you could design it through the user interface. And here, on the other hand, you are writing more detailed queries, but this is as flexible as you can think of. You can write any kinds of data extraction SQL queries, put this into this whatever templates the way you want it to look like, provide the report editor to something like this, and then finally produce a report that could be a PDF or could be an HTML page or what have you, right? So what I wanted to show here is another example. So if you click on this link and basically you can go through a step-by-step process of building something like this. And in the coursework, we give them assignments of the approach that you want to take either through this or through this, right? The next kind of approach we also take is to be able to do cohort-based queries, right? So within the EMR, what we do is that a set of, you can build your own cohorts using this module called Cohort Builder within the EMR. You basically have concept-based search that you can do. So you can identify any dictionary concept that you want to use. Either it's a reference term. So for example, systolic blood pressure is a concept, but you can also take systolic as the synonym term that is internal to the deployment, right? So it maps to a LOINC term or a SNOMED term, and then allows you to search all patients who have had um, any observations on these concepts, right? And then it will return view some of the list of the cohort. And then you can add additional things like patient attributes. So you can say people who are having initial visits, people who are doing return visits. You can select gender, age, birth date. So all the things that you probably want to do to create a construct a cohort. You have these separate queries that gives you some sample. From that sample, you then further filter the sample by doing and or not, what have you, logic. And that will finally create a saved search. And that saved search could be run again based on when you're seeing new patients. So if you want to do this monthly export of cohorts, you could do that by rerunning this cohort builder query that you've run using the user interface. So this allows you to write what I call ad hoc queries to build cohorts and then export this data or work with this data to do further analysis, right? So this is basically a data extraction mechanism that we teach in our course that allows us to understand the idea of cohort creation to be able to do retrospective studies. This is another thing that we try to teach in our program, but I think a lot of countries use them. So DHIS2 is a data warehousing platform that can take data from OpenMRS, which is the medical records platform, and send it to this data warehouse. The data warehouse then is very widely deployed, so it's a global standard. Over 130 countries in some way around the world use this platform. And what you can do is think of this as something that the federal government or the state government hosts or a peer could host. In a few countries, some payers actually host this. So you can take your, in the US, what we call as QRDA 1 or QRDA 3 reports, that are either sent quarterly or monthly to do reimbursement, or to be able to do like the leaderboards, the comparisons of hospitals that the CMS does. So that data can then be automatically sent or generated from the EMR, sent to this data warehouse, which then acts like it can look at that information to be able to do some kind of analytics of comparing facilities or comparing hospitals. So this kind of platform in particular is used by the Uganda EMR, who have built their platform on top of OpenMRS, but they have included this DHIS2 report module as part of their distribution, because that's the mechanism, the infrastructure that they've built, which is at the state or the federal government, they have DHIS2 to compare facilities and look at the quality improvements within facilities. And then facilities have OpenMRS, which is then sending this data automatically every month or every quarter to be able to do reimbursements or quality improvement programs. So we try to teach this to students about reporting, finding parallels with how our system here is sort of using QRDA 1 and 3. However, all of these are ad hoc. What I mean by them is these are separate sort of solutions that are not fully standards based. So there is no fire interchange. There is no CDS hooks, for example, for decision support. Even though this is an IHE standard called ADX for sending data from OpenMRS to DHIS2, it still is a very uh, small set of adopters for that standard. So which is why I think most of this is non-US standard. So if you look at the CCDA documents, or if you look at, say, the QRDA XML that the CMS requires, those are very different from all that I showed to you, right? So then I think the question comes, because we were doing this from 2016 to 2019 or 2020, when we were teaching this, the question that we got often asked is, we are learning these concepts, this is great, but can we do this in our jobs when we work with US health system? And the answer often was, there are similar tools, but not the exact tools that an Epic or a Cerner or a eClinicalWorks would use in the US healthcare setting. So the question was, each of those EMRs have tools like these, right? So there's a cohort builder, there's a reporting tool, and all of that, but it is still not standards based. So then in the last 4 years, what we've been working on is this platform called Open EMR. It's a very opinionated EMR that's built for meaningful use, or certified EMRs as they are called now. It's a ONC complete ambulatory EHR that's been certified by a testing laboratory that gives the certificates, and then there are audits to monitor that it is one of the approved EMRs that are required to be able to get the incentives from meaningful use, right? But what we did in that, what we had learned from our OpenMRS experience is, without real world data, all of this is just a toy box rather than something that would really build the competencies of real world use. So what we did was to take mimic data, which we had already taken into OpenMRS, into this. So we have done some kind of field mapping between what mimic releases for the ICUs and hospital modules. We do an ETL process and then load that data into OpenEMR. So basically, OpenEMR has all of the vital signs information. It's got medication information. It's got billing coding information. It's got encounters. It's got notes, because we also import data from the notes module, and then put it in there. So So very much how a real world workflow, even though in sort of an ICU setting, we've been able to import that um, and use it in our courses. And we've collaborated with other institutions who are also using the same platform to be able to teach some of their courses. And I'll showcase some of the examples of the way in which we are using it in some of our courses. Um, and, and and what I want to distinguish here is maybe a lot of people have used EMRs like Epic, Cerner in their programs, right? What we are talking about here is not the same as training nurses or clinicians in EHR use, right? We are training informaticians who would be able to use EMRs by customizing the EMRs in a way that that is innovative and allows us to improve workflows and things like that. So it's informatics training using an EMR rather than using an or rather than training how to use an EMR. So I think that's the biggest difference that I'm trying to highlight here is, so for example, this is one course where we use OpenEMR to teach decision support rules and building clinical decision support rules within an EMR, right? So if you were actually at an Epic site or a Cerner site or one of the big EHR vendor sites, it would be very, very difficult to have your students get into the hood of the database or the have smart on fire connections and all of that, and build and modify and create clinical decision rules, right? And when I say students, I'm talking about our class sizes being close to 60, 50, 60 students wanting to do this in the coursework, right? It's really hard to do this with those vendors. So which is why I'm trying to highlight that this has really worked for us because it's open source, but also because we've built real data and manuals that students can learn and fail and learn and break things, which they often do, but it's in a safe environment where we can replace it fairly quickly and get back to a stable instance, and they can again work and break things and make it work again. So it's a iterative process of learning where students break things because they're given administrative rights to be able to build some of these rules. But that is basically how they discover and learn much better than just observing somebody else do it. For example, the CDSS course, which is B642, it offers a deep dive into using CDS, but also not just looking at how the rules fail or work. So you've probably heard of the concept of alert fatigue, but when students, when 50 students build their own rules and each student or each group builds at least 2 or 3 rules, you get 150, 160 rules. And then students experience what a clinician would in alert fatigue, right? And then they start to realize, oh, this is a problem. Every time I open a patient, I go to a patient dashboard, there are like 50 pop-ups that coming up one after the other. And we have to think of ways to integrate these rules together. And then they start experiencing or fixing the clinical decision rules because they have seen real world problems of alert fatigue rather than just the concept. So this is how they do it. There are a set of rules like these. These are then configured for any of those patients of different conditions that look something like this. So there is the summary part of it, which is if it's an active alert or a passive alert, what is the sort of background literature, a clinical practice guideline for it, who's the developer, what is the funding source. So there's some summary description, what is the kind of reminder interval when they should show up, all of the demographic filter criteria on the kind of patients for whom these rules should show up, the target groups, what kind of clinical issues they have or should be covered. For example, one of the very interesting sort of meaningful use required or full reimbursement required is that anybody who is a diabetic patient or who has any of the codes related to type 1 or type 2 diabetes with an age has to have an eye exam, right? So it's one of those things on which you might get full reimbursement as a health system, or you might not get full reimbursed for the services if you've not done the eye exam. So that's a clinical reminder that students learn how to build without causing alert fatigue or being able to correctly create it, right? So that's sort of the competency that students develop through real world data, through real world practice within the EMR. So that's um, till part 3 where we are at the moment, but something we are trying to build for the future is called the Excite project. So as you see here, what we want to do is a collaboration with Paul and others in the academic forum at the American Medical Informatics Association to be able to use standards-based approaches um, to do this in a way where we are still using real-world data, but we also have workflows that are real-world within the EMR, but also real-world tools for doing analytics, right? So as you may or may not know, but Odyssey, which is Observational Health Data Sciences and Informatics, is a large community of pharmaceutical companies, of health systems, of government and federal systems who have collaborated to build tools and analytic tools using standards-based approaches. So a workflow that's real world, analytics tools that's real world. How do we give this experience of when a patient walks in, all that data is captured. That data then can then be created as a cohort for running cohort studies within tools that the industry uses, right? And then how do you create like an authentication authorization from your classwork, and any assignments that are done then fit into your LMSs, learning management systems, right? So all of this, and then you can also run individual sort of notebooks in Jupyter, for example, with these, or you can same observe those cohort extracted things and do analytics on this side, right? So that is sort of the Excite project that we are working on. And we'll do use tools like these. So patient data, which includes demographics, history, that data will move into the from the EMR through an ETL process. So White Rabbit is one of the tools that people use often, or Rabbit in a Hat with Athena. Athena is where you get dictionary concepts mapped from local dictionaries to concepts that are reference terms. Then we do some transformation using SQL scripts and R packages, and then load that data and observe it in data quality dashboards. So I'll get into depth of each of these steps in a bit, but the idea is to then convert an EMR specific data set and get a snapshot of it in a common data model, right? So this is a live active system where data is going in all the time. You can do some data extraction using ad hoc reports, do your cohort analysis, but that does not flow well into other health systems that use other kinds of EMRs, right? So we come to a common data model, which will allow us to then use all of these different analytics tools from the Odyssey, as this is called, in the Odyssey set of tools, right? So this entire package is open source, so you can actually look into the hood of the vehicle and of the car, of the infrastructure, and be able to fix things and learn from fixing things. This is Atlas. So Atlas allows you to do the same cohort analysis or cohort extraction that you could do only in your own EMR, right? But we'll take that data, move it to the ETL process, and get to the data model. The data model itself has a lot of analytics tools. So you can do cohort definitions, characterization, incident rates. So all the data that you have moves here, and within the CDM, then you run the Atlas. So Atlas here is a separate tool that we deploy. And then that deployed tool will be able to do cohort extraction, and then you can export this out to other tools that can then allow you to do analytics, or right, do statistics on it, right? So if you wanted to do statistics, you have R packages. If you wanted to do transformation, there are other packages. If you wanted to um, do survival analysis, for example, there are other packages. So a lot of other tools you can then use once you've exported data into the CDM, and from the CDM into Atlas, which allows you to do those kind of things. The other thing that I think we've experienced in some other projects um, is the data quality of this export is a moving target in some sense, because there are new workflows that are designed within the EMR, new forms that are designed within the EMR, which contain different kinds of data. So the ETL needs to get updated, um, not very often, but at least um, once an academic year, at least in our case. And then in that process, we have to verify that the data that we're getting is complete. So then the plan is for Achilles integration. Achilles is a tool that allows you to get data quality dashboards like these that will tell you what kind of tables or what kind of fields have how many records, right? And then within the EMR, you can look at how much data is actually present, and then see in the CDM if that data export has happened through the ETL process. So you can validate your ETL mechanism or ETL process by getting into reports like these, right? So if you think of this thing, you can then look at the results table that are generated from the CDM transformation, and then look at it from either the data quality dashboard or like a density report that looks like this, that tells you all of the different functionality or um, different tables and fields have actually moved correctly or not using the ETL process. So you could do data source profiling using demographic conditions observations. You can do completeness using the data quality metrics. You can do temporal characterization. So patterns like over time, are you missing data for certain kinds of individuals or certain kinds of programs? And then you can also do population level statistics to identify if the study that you want to do you have the patients for those, right? So if you do this in the mimic data that we are using, you know that this is an ICU hospitalist setting, whereas if you wanted to do something more ambulatory, or an MCO, a managed care organization that's doing, I don't know, maybe long-term care or geriatric care, that kind of data won't be available in the CDM that's converted from our OpenEMR, right? So that kind of thing, those kinds of things you can identify by doing this transformation and use of Odyssey set of tools. The last set of tools that I want to highlight is basically an endless set of things that you can do once you've got the data into CDM. But this is only a small environment that I'm talking about for one of our biomedical analytics class. The idea is that once you have the data in the CDM from the EMR, you can have many different kinds of R-based packages. Hades is one of those projects, or I know was the right term for it, but it contains a lot of packages, a package suite that allows you to that have many different kinds of use cases that people have built for their own studies. So you can use all of those tools that other people are using in the community, in the Odyssey community. For example, patient level prediction package is really useful for looking, forecasting, and identifying um, conditions or trajectory of a patient. Um, then you can also do like the Shiny app builder allows you to build dashboards, which look really that allows you to give a snapshot view of the kind of patients that you have. Um, you can also do other kinds of packages that you can use, and you could teach courses in statistics. You can teach courses in analytics. You can teach courses in warehousing, and all of these could use the Hades environment. So this is our plan for fall, where we have a biomedical analytics class where we want to take EMR data and teach this using this integration. So that is sort of where we are. What I want to finish this talk with is what is the best way to teach health informatics for data and analytics competencies, right? I think the broad question is, can you drive, can you learn driving without ever sitting in a car? And most people will tell us maybe I can learn driving, but I won't be able to become a mechanic who can fix the car when it fails at some point, right? So I'm actually a good driver, and I've learned how to use my EMR, and I can provide good clinical care using the EMR in a fairly efficient way, but I don't know how to do cohort studies, or I cannot build a data extraction pipeline to be able to do the cohort study, or I cannot um, build a clinical decision support rule, right? So what I'm talking about here is a different kind of competency. So not everyone needs to be a mechanic to be a driver, right? So you do not have to know like which wire gets activated, or when you clutch, what happens to the gear, so that you can switch gears and all of that. You don't need to know those details to be a driver, right? So what we are talking about is, as informaticians, we should be able to know these internal parts, and open source tools and frameworks that we discussed today can allow you to do that. You do not only have to be an EMR user, but you could be fixing things, improving things that are breaking down, right? Often clinicians complain like the EMRs are not usable, or they take too many clicks, or finding information is really hard, right? To be able to fix those things, you have to have these competencies, which is why you have to be an interdisciplinary person, or with interdisciplinary skills, where you do know the clinical practice, you do understand the clinical practice, but then you also know how to go under the hood of the car and fix things or modify things to be able to do this, right? And we want to do this through not toys that you can play with, which means you don't want to do this through a Kaggle data set that is already extracted, cleaned, and easy to do statistics on. Or you do not want to get Mimic itself, which does not have the workflow information, but it has data from the ICU, right? What we are talking about here is how the data would be within a health system, within the EMR, how that data should be extracted in a standards way that can then be sent to analytics tools, but could also be then further cleaned and modified to be able to do analytics on. So experiential learning, where students experience how it is in the real world, and produce something out of it, right? So not just observe, play with toys, observe real world practice, but rather be part of the real world practice and produce something that's meaningful and useful for um, research or doing analytic studies, right? So that's where I want to um, leave this by thinking about this is a necessity, in my opinion, to be able to teach health informatics, and for students to really know how to be ready for the workforce needs when they finish health informatics programs. And it's a team science, so all these collaborators have helped shape whatever I talked about. And some of these are graduate students, some of these are collaborators who I worked with. Um, the central part is the team that has worked on a lot of these things over the years. And thank you so much for letting me speak today. Thank you.
Perfect. Thank you so much. I am so excited about this platform. I just think it is amazing how much we can teach in the field of informatics between Open EMR and Odyssey. And it was really interesting. I like your analogy too between drivers and driving instructors. I was trying to think of what's the role of the informaticist, and I was discussing this with Harold a little bit. We were thinking, so what do you think of the role of the informaticist? So we're not the car manufacturers, that's going to be the vendors. We're often not even the mechanic, but we certainly are the mechanic instructors, right? And then probably we're also the NTSB when things go bad in terms of investigating why there's failures. And so I was wondering, is there other roles that you can see with an analogy for informaticists? I see in some ways we can be driving instructors for usability and training purposes, but I don't know if you had any other thoughts, but I like that analogy.
Yeah, I think those are really good points of how informatician informaticians have to play a role in all of these different aspects, but not just be learning driving, right? So it's not the driver role, um, because yes, there are clinicians who will use the EMR who are also informatics trained, but the real informatics skills that they need to demonstrate, competencies that they need to build, is for these other roles.
So we have a couple of questions from the audience. And so the first one's from Brianna Lee, and her question is really about ways that you can integrate prediction tools into Open EMR. And I guess, are there, you mentioned the CDS hooks, right? As a way of doing simple cards, right? For just simple prediction tools. Are you doing more like, are you looking at Firecast or some of the other ways of actually bringing UIs together where they could do predictive analytics and show graphical predictions?
Yeah, so some of my students have, or at the moment, are building smart on fire apps for different use cases. So, and these apps work across EMRs because of
Gotcha.
the fire.
And so the smart on fire apps would launch out of the Open EMR.
Yes, so they would
Yeah.
launch out of OpenEMR with the data from OpenEMR, but we are also doing this at Cerner, with Cerner. So it's getting data with the same things and then visualizing for, this is for end-stage liver disease patients. But basically the end-stage liver disease patients and the the PROs, the patient-reported outcomes data, also comes in from REDCap. So it integrates data from the EMR, from REDCap, in the Smart on Fire app, that then allows the clinician to take better care of their patients. So in that sense, that allows us to build um, better visualization tools and better analytics tools for the clinical purposes.
I could think of so many different classes that we could teach. So we began teaching with OpenEMR this year with our fire course, and it's been really a big success to show the two sides of it. Have you also thought about, and I love the idea of having this platform having more hooks in it to allow us to do teaching activities. Have you thought about our ways, I want to teach like usability, and so I want to make some bad EMR examples of things where it's very hard, where data doesn't flow well, or it's hard for the user to make a decision. And so, are there ways of actually, I guess, trying to intentionally create scenarios like that for teaching purposes?
Yeah, so I can tell you three examples in our CIS class, or Clinical Information Systems class, where we use the EMR, and students have to do a usability study as part of that course. And there we have built deliberately bad UI examples. For example, we limit the number of tabs that can be opened simultaneously to three.
Uh-huh.
So we limit that,
Ooh,
and then
yeah,
we force it at 3, and then we expect students to talk a little bit about that. And then we've designed two templates. One is a bronchitis form, and the other one is an I form. So I form has very good details about what somebody would do in an eye exam, and the bronchitis form is a very open, just 5 fields, right?
yeah.
And you can do a lot of text notes there, but again, it's very textual, not structured. There's no way in which you can describe and write what you want to, but there's no structure to how you can take that note. Whereas in the eye exam form, it's very structured. You have every part of the eye that you can take notes on or mark check boxes and things like that. And then we ask students to look at the usability of both of these approaches within the EMR for those use cases, and then talk about usability of those.
That is fantastic. And I guess since it's all web-based, you could actually do some time task analysis with the DOM screen. Have you done any of the web analytics of actually the metric of how much mouse movement there are in the tasks?
Yeah, so we did that for one of the course projects, where we looked at, and so we have a published paper on this where we use the POGIL concepts, and then we measured how students are following the process. And when you diverge from the process, what happens to the concept that you're learning? So like I said, we've told them do step 2, step 3, step 4, step 5. We already told them, but the concepts that they have to learn and then answer a quiz out of those learned concepts, what happens when they don't follow the steps, or we merge the steps in a deliberate way, and we look at the EHRUs and correlate that with it. And we found some very interesting findings that process-oriented guided inquiry learning works if the students are not diverging too far from the steps, but their conceptual understanding is stronger when they play around and do not follow those steps. So it's a very interesting mix of how you can teach, or you do not give a very structured steps, but you keep it fairly open so that discovery still happens and the competency is also learned.
That is just great. And we have another question from Robert Barrett, one of our PhD students, and that is, I guess, of course, is there hooks in there for us to plug in generative AI? The questions are, can we, are we going to be able to do some questioning or some prompting or guiding or of the student to see, how they're using the information?
Yeah. Um, so this is something we are working on, and I'm hoping, um, yeah, I don't have the students who are working on this, but this is an abstract that we've submitted. But the idea is that like I described, the CDR rules that students create are often breaking the system, right? So what we have done is we've hosted a local LLM, Llama basically, and then students submit
Yeah.
their form onto it, of the CDR rule, and then it tells what the errors are before students enter it into the EMR. So it's a separate form, a PDF where they fill in the actual rule. They put it to the LLM. The LLM gives them an answer about what to fix, and then they put it into the EMR. So it teaches them
Yeah, I
in
like
that
that.
way.
It's externally. I also want something internally integrated so they know what page you're
Mm.
on. It can ask you specific questions about the patient and then see, basically you're basically, integrating into an LMS in that way. You're basically having questions that you're having of the patient at different points of their navigation of the record. That is fantastic. So we do have another question from Lalitha Pulavarthi. And so I'm going to modify her question a little bit. I really like the course you put together on ETL, structured pipelining between OpenEMR and OMOP, but it really raised the question of why it wouldn't be also a great opportunity to teach FHIR, to use FHIR as the means to go from clinical systems into the OMOP model. So I kind of like the OMOP on FHIR side of that piece as well.
Yeah, I think it's somewhere between efficiency and what we have.
Yeah.
I think bulk export is sort of an issue we are dealing with, and
No, no,
from
no. You wouldn't want to do it on a ton of a ton of patients. I would agree.
right,
But it could, for showing how to do the transformations, it could be useful for doing that.
right, right.
Yeah, that is really exciting. And yeah, I do feel like there's a lot you can do from when it goes into the OMOP side to go kind of go back and forth between what it looks like from a large analytical longitudinal view to population level view to an individual record within the health system. I also kind of like, I would love to have to the point where we can do examples where we might have like a 500,000 patients in there, and we can say of patients like, and we can do some temporal, playback where at a certain point in time where you know what's going to happen to the patient, but it's not, we withhold it from the EHR, and we kind of have the person try to make decisions and predictions during that person's case of based on other people in that database, for what they might be able to try out, what decisions they're trying to make, for what orders to make, or what decisions should be done on the patient.
Mhm. Yeah, no, I think that's going to be fascinating if those tools are available. Currently, they're sort of disconnected, and um, that connection is something that students have to make themselves in their heads.
Yeah.
If there are user interfaces that allow you to do that, that'll be great. Yeah.
Well, it'd actually be pretty easy with OpenEMR. What I would do is I'd basically program a HL7 fire server to be sending those messages in at a sequence, based on a timestamp. So you actually could like replay a patient's record over time and kind of show what things happen during, as you go through the trying to make decisions around the patient's care. Uh,
Mhm.
Really exciting. Okay, so we had another question from Robert was around, do you see how we could use this for simulating disaster recovery, real world situations? I've already mentally thought about how I can use this to look at the simulation, the Friday night and the ED phenomenon between the ED, the OR, the PACU, and the floor, and trying to be able to simulate how that is a difficult queuing problem. That would be a fun. I can see that being a good student exercise as well. But do you see any other like disaster recovery situations that you could use the platform for?
Yeah, I mean, I think the fire havocs that have happened. So I think the you can replay, right? Like,
Yeah.
so you've observed this in population, but now you want to know how that story happened. So you can actually go back and replay those things and observe them. So I feel, yes, for situations, public health crises and things like that, it'll really be good evidence, but also better understanding of what could made better in the time.
Yeah. Uh, Fantastic. Really excited. And I just see so much opportunity. Harold, do you have a question? Oh, we're down to 2 minutes left. If there's any other last questions, I want to make sure I got to everybody in here. I am certainly am excited by this process because I do feel like this really helped between these two platforms. We can modernize a lot of informatics education and really try to help and with these public data sets in this process. So since you're using Mimic, are you having the students go through their city training to be able to go through the DUA license? Are you able to incorporate that as part of the educational goals?
Yes, so we've discussed this with Mimic and have a DUA where we are signing the DUA, and then because we're not giving the entire data set to the students, but rather using them with that, and we complete CT training and HIPAA training for our students at the very beginning of our program. So that's how we have the DUA covered. So any institution or any site that wants to use the same infrastructure will have to sign the DUA themselves as an institution,
Yep.
and then the students will use it. Yeah.
And I do think the city training is very useful to incorporate as part of general training of our students in informatics on understanding the history of research and how we conduct research on medical records.
I think we have a question from what is the importance of the patient? I didn't quite catch that for training anything with patients. We're not getting into the patient portal aspect of it.
Well, I really like the idea of a patient agent in OpenEMR. Certainly from like if from even from like a patient portal with asking questions and trying to understand their patient record, because I think that's really is a very important informatics question, as well as of course how they're involved within their healthcare. Is there a patient portal side to OpenEMR?
Yes, yes, there is, and one of our attendees, I think, is working on that part where he has a mobile app. Chandra Vikram, who's in the attendees, he has a mobile app that is the patient-facing side of the Smart on Fire app that I talked about for end-stage liver disease. So he uses the patient portal access and the Fire API from there, and also communicates with RedCap on a mobile app, which also has an LLM, interestingly, for patients to understand their problem. So he's customizing it to the ESLD care, so the LLM doesn't hallucinate and things like that. So it's fairly um, interesting what he's been able to achieve.
Well, wonderful work to you and your team. I really appreciate you presenting it here. We have certainly really benefited it greatly within our educational program, and we're excited to collaborate with you. So thank you.
Thanks so much.
All right,
Thanks for this opportunity to speak.
absolutely. And with that, we'll conclude our grand rounds for today, and I hope everyone has a great day. Take care, everyone.
Thank you. Bye.